I may skip through a few slides in this session depending how much interaction we have to get some bits at the end. You may hear a lot about biomarkers. We have biomarkers for cardiac disease, we have biomarkers for sepsis, we have biomarkers for thrombosis, and people are very keen to use these things to refine our clinical practice, and there's a whole host of AKI biomarkers that we looked at, and people have been very keen to look at these in intensive care. And you will even have, or would likely to have in the near future, salespeople coming along and trying to market AKI biomarkers to refine your practice. And the question is, what are they? Are they useful? Why do we need them? Can they help us? And how do we study them? So, in this talk, I'm going to give a bit of an outline. What is the clinical problem? What are the limitations of current diagnostics? What novel AKI biomarkers do we have available? How do we apply them to clinical practice and future approaches to research? But let's start off with some clinical scenarios. I apologise to Marlies, who's seen probably most of these slides before. Anyway, this is a 75-year-old lady with community-acquired pneumonia who has diabetes and atrial fibrillation. She's got a kind of borderline-ish blood pressure, lowish diastolic, a bit tachycardic, low-grade fever. She's got not terribly high respiratory rate. She's got a creatinine of 100. We don't really know what her baseline is. She's not requiring much oxygen. So it's tricky to be able to determine this lady's level of risk, right? Does she need to be admitted to a high dependency unit? Could she be discharged with all antibiotics home? Does she need to go to a general ward? You could imagine that all of those might be appropriate for certain patients, and a whole number of patients may present very much like this. And one of the important complications of community-acquired pneumonia, especially in a 75-year-old lady with a creatinine of 100, which is not normal for a 75-year-old lady. Normal creatinine probably would be around about 65. But of course, you could have chronic kidney disease. You could always have a creatinine of 100 and have no physiological abnormality. The AKI is certainly an additional risk factor for complications and a sensitive marker of physiological instability. Can we refine on that? So, does she have, is she developing AKI? Where should she be managed? How should she be resuscitated, if at all? Does she need more resuscitation? Will her AKI affect outcome? And those things we don't really know. But there, we do have some evidence about these things that we look. So this is a study from John Callum's group in the States. And the important thing about this is that this is a group of patients who were actually not that sick and didn't initially get admitted to the intensive care units, and you have to be pretty well not to get admitted to an intensive care unit in the US. And what they found was that AKI was associated with significantly increased mortality in groups defined by severity of pneumonia index or their curve 65 score, or who didn't have severe sepsis or didn't come to the ICU. So if you could delineate the patients who were developing AKI, you would certainly have a strong association with outcome, and it could be, you could make a very reasonable argument to say that a population that might have a 1-year mortality of 35% probably should benefit from admitted to the ICU. And a substantial number of patients with non-severe pneumonia developed acute kidney injury by current definitions. Okay, so clinical scenario 2 is a man who's had an open cholecystectomy. He's got, he normally has high blood pressure and moderate LV function. He's not very well analgesed. He's got, again, a lowish blood pressure probably for his baseline. A bit of a negative base excess and a lactate just above the normal range, and he's had 4 litres of fluid, and he's not passing much urine. And the question is, does he have or is developing AKI? Where should he be managed? How should he be resuscitated? Does he need more fluid? Does he need vasopressors? Will the AKI affect his outcome? Is this urine output just the effect of him having surgery, being pain, having an inappropriate release of antidiuretic hormone, perhaps having had a bit of pneumoperitoneum, or is this really an indication that he's got acute reduction in GFR? And are there clinical, can tests help us to determine these things and enable us to better treat our patients? Just to let you know, after acute kidney injury after surgery is associated with long-term risk of mortality, and this is true across all age groups, and across all genders and across different forms of surgery in this retrospective study. Certainly, if the patient does develop AKI, that's got very significant clinical implications. The problem is we're unable to risk stratify many patients early in the course of their illness. Current diagnostics are inadequate to enable us to identify AKI early, and this is when we'd like to intervene. Okay? Late interventions may be of less benefit to the patient, certainly in terms of preventing acute kidney injury. And also you want to identify patients who've got established AKI, who are not going to generate a better urine output, and avoid harm, particularly probably from excessive fluid loading in these patients. So, let's find out who might benefit from hemodynamic or other interventions and who we should concentrate on supportive care and avoidance of secondary injury. Conventional diagnostics of AKI are based on serum creatinine and urine output. And serum creatinine and urine output aren't bad, and they're certainly a hell of a lot better than ways in which we have to monitor liver function, or even heart function, or brain function. But they're not, they still have significant deficiencies, particularly in patients who are critically ill. So you're aware, I'm sure, from talks about KDIGO definitions of acute kidney injury based on varying degrees of oliguria or fold changes in serum creatinine. So, stage 1, a 1.5-fold increase, or perhaps this very small 26 micromole, sorry, that's come out, increase within 48 hours, or a 2-fold or 3-fold increase or need for renal replacement therapy. But it's important to appreciate what actually determines your serum creatinine, to appreciate why these diagnoses can be delayed or imprecise in critically ill patients, and why we may need better tests. So, normally your creatinine is stable, okay? And that's, you're in steady state, and you've got creatinine production, and you've got creatinine elimination. Creatinine, as we heard this morning, produced mainly by your muscles, also some from the liver and not from your diet, or a substantial amount from your diet. And elimination is going to be equal, because creatinine is almost entirely excreted by glomerular filtration, with this very trivial amount of tubular excretion, which we'll ignore for the moment, is GFR times your plasma creatinine concentration. And so what this means is that GFR will be related to the reciprocal of your plasma creatinine concentration, as long as and if you're double your creatinine, your GFR will halve, because you'll be putting a 2 here, so that will mean you're essentially dividing your GFR by 2. As long as your production is stable, and as long as you're in steady state. Okay? And obviously if your GFR abruptly changes, your production rate abruptly changes, then this won't be equal to anymore, and the levels will have to change until you are back in steady state. So if your GFR halves, then your creatinine will slowly rise until it's doubled the concentration, as long as your production has remained stable. Okay? So this is the relationship between plasma creatinine and GFR at steady state, and just so to illustrate, if you halve your GFR, you'll double your serum creatinine. But what you can also see is, because it's a reciprocal relationship, that very quite large changes in GFR up here, when you're going from 100 to 50, resulted in relatively small changes in creatinine, whereas the halving of GFR down here is actually a smaller absolute change in GFR, but produces much larger changes in creatinine, because you're doubling from a higher number. So it actually, a change in your creatinine from 70 to 90 probably has very large implications, whereas we're much keener to note a creatinine going from 280 to 400, but in fact the implications in GFR are very similar. So just to emphasise, you've heard again this morning, creatine comes from your liver or from your diet to muscles. You make creatinine that's excreted in your kidneys, but obviously critical illness can affect muscle metabolism. You have changes in your diet and changes in liver function, and all of these alter production. There's some data on this. This study was essentially looking at creatinine production in patients who were on hemofiltration. There's a number of different estimates here, but essentially if you compare this is the measured creatinine production in the patient, because they've essentially measured how much creatinine's in the ultrafiltrate. The patients weren't producing any urine and their creatinine was stable. So what they're taking out of the patient is equal to what they're producing. And Up here is actually the estimate of creatinine production in the population based on the most recent formulas that kind of estimate creatinine production for EGFR in terms of saying what a normal person of this age, race, sex, and body mass would be producing in terms of creatinine. So what you can see is that when you become critically ill, you're making not much less creatinine, which means that actually if your creatinine rises, that your GFR decrease has been much larger than you may be otherwise appreciating. And this just illustrates this. This is a 75-year-old male whose GFR has decreased from 82 to 25. And the blue line shows what the creatinine would, how the creatinine would increase. And you can see it's going through these different definitions of AKI. This is the older terminology, but this is essentially stage 1, stage 2. Stage 3 you're not quite getting to because it's not quite been but you will do eventually over a long period of time. Officially you should do because the GFR has fallen by more than to a third of, to under a third of what it is. But that won't actually happen for many days because the rate of rise is relatively slow. But what you can see is if you superimpose a positive fluid balance on to cause a degree of creatinine dilution, that has a small effect, not as big as suggested in some papers actually, but actually changes in muscle mass and creatinine production of only a 20% decrease, and it may be much more, really blunt the rate of rise of your serum creatinine. So even though at this point the GFR is 25, it's acutely changed, because that's happened very rapidly, let's say the patient's had surgery, a cardiac arrest, some sudden insult, it's actually going to be 6 or 8 hours before you even get to the 26 micromole increase, and you're not going to be recognising him as having AKI2 till 36 hours, and he's never actually going to get to the AKI3 that officially you should do in terms of the change of GFR. So that means here that creatinine is telling us a lot less about the patient than we would desire. It also means that EGFR is completely useless in critically ill patients because they're not in a steady state and they've got altered creatinine generation. So EGFR is of no value in the acute setting. So the limitations in existing diagnostics, creatinine is an insensitive related indicator of AKI. It's indirectly related to the tubular injury, the pathophysiology, because it's just something that's reflecting glomerular function. Oliguria, unfortunately, is not very sensitive and specific, because we said if you have tubular injury, just be honest, your urine output should go up until you become very, very unwell with a very low GFR. And so the problem with specific interventions for AKI may be that the diagnosis is delayed and imprecise. Okay. Now, that's not to say that creatinine isn't good. Creatinine is like an ambulance. It's probably brilliant for most of our patients. Okay, most patients in the hospital, most patients even in ICU, potentially, of normal operative surgery, creatinine probably will suffice. But there are certain situations where you have somebody who comes in very sick, or you have difficult decisions to make about where a patient goes, where you need some better technology, and, you know, do we have better technology? That's the question. So we're not saying that, I don't interpret me that we shouldn't pay attention to serum creatinine. It's certainly a hell of a lot better than what, say, hepatologists have available. So what's a biomarker? So a biomarker is merely a diagnostic test for the presence of specific pathology. So plasma creatinine or quantification of urine output is a biomarker. But do we need newer, better markers? They have to be more specific and sensitive, and we want them to be ideally connected with a pathology of interest. We want them to give us information very early on, okay? And the question is, do we have them? And the other question is, if we've got these markers, there's no point in just having them if you can't do anything about them, okay? If you had, let's say horoscopes are accurate, right? And you read them and they said you're going to die next week, right? But there was nothing you could do about it. Well, I think you'd rather not know, to be honest. You want to have some intervention that you can make. So urinary biomarkers we have AKI biomarkers could either be urinary or in the blood. Now, there's been a lot of concentration on urinary biomarkers, probably because they more accurately reflect what's going on in the kidney. And there's lots of biomarkers in the blood that may be more indicators of systemic inflammation that correlate with AKI, but they may not be terribly specific. And they've been kind of classified in different ways, but essentially you've got some structural markers. These are markers that can be produced in the kidney or released in the kidney in response to injury. There are also some functional markers. These may be things that appear in the urine because the tubules aren't working and they let them fall out into the urine, or or they may just be more accurate reflections of changes in glomerular filtration. Or they could be things that come into the bloodstream because they're released from the injured kidney or rise in association with acute kidney injury. But probably this group of things that are actually made or released from the tubules in response to injury are the most exciting group because they're probably more specific for the pathology. For instance, things that are just functional markers reflecting loss of tubular function may also be abnormal in patients with chronic kidney disease. And the aim for biomarkers, as I've said, is to try and look to see if you could take patients early on, identify them at risk, to see if you can accurately reflect the patients who've had significant decrease in GFR, to see if you can identify the groups who just need supportive care, but also to perhaps be able to prognosticate in these patients about things like renal recovery or detection of secondary renal injury. And there are a number of different biomarkers that have been studied, and some of them are touted to be better at different stages. The original biomarker, so to speak, was NGAL, and this was identified by a kind of a genetic approach. They screened a lot of RNA expression. They found that NGAL was specifically elevated. They found a lot of other candidate molecules. They screened NGAL. This is a mouse model of renal ischemia. Okay, and they found that the NGAL went up for 3 hours and the serum creatinine only rose in 24 hours, and they found NGAL expression in the tubular lumen. So they really felt this was quite specific, but obviously this is a mouse who has completely normal kidney, and then you're subjecting it to an acute insult, which is ischemia. And that's very different from a human being who has got a very aged kidney, who is having a variable and heterogeneous insult, such as sepsis, nephrotoxins, dehydration, etc., etc. NGAL is an interesting molecule. It has some iron chelating activity. It probably has a biological role in sort of protection against urosepsis, potentially, but it's upregulated injured epithelial via markers of inflammation. And that's not just in the kidney, but in the lung and in neutrophils. There are some workers made a reporter construct which was the NGAL promoters. They could basically make their kidneys light up with a marker when NGAL was activated in a transgenic mouse model. And what they could find in this was, and actually this was a fluorescent molecule, they could actually detect light coming off these mice. And they did unilateral ischemia reperfusion, and what they found is that the kidney that had been subjected to ischemia lit up. With longer ischemic fusion, it lit up more. And interestingly, when they dehydrated their mice to give it kind of classical pre-renal dysfunction, they could make the creatinine go up, but actually there wasn't tubular injury in these mice. So that, indicated that NGAL was pretty specific. And clinically, they took the next best thing to mice, this is actually a bit before that, which is children, and having a cardiopulmonary bypass. And these children have it's a very clean model, and some of them had a very significant acute kidney injury and some of them didn't. And you could see there was a huge change in NGAL and it was terribly predictive. I have to say though, if you've gone to look at these children, some of these children would be having relatively simple procedures, and some of them would be having an arterial switch operation or some very complex procedure for correction of multiple congenital defects with a very prolonged bypass time and things like that. And actually what they haven't told you is whether you could have just gone and looked at the children and said, look, this kid's obviously going to get acute kidney injury, and this kid sailed through their relatively small closure of a PFO or something like that, I don't know, and they're very low risk of acute injury. But nevertheless, this looked brilliant because it's the first publication it got into the Lancet. Interestingly, there's some other research they did in the emergency room, and what they found here was, this was by screening records look afterwards, they found that NGAL was significantly elevated in patients who went on to have a diagnosis of acute kidney injury, and it was much more specific than the presenting serum creatinine level, as you would expect. So obviously serum creatinine was elevated in chronic kidney disease. It wasn't so much, whereas the NGAL wasn't. and they found they made up a composite clinical outcome which included such things as having a nephrologist ask to come and see you, and they found there was significantly increased odds. So there was at least some evidence here that screening this in emergency admissions could be helpful, but obviously there's quite a wide variation in NGAL levels here. So loads of people jumped on the NGAL bandwagon and did loads and loads of studies, and some of them looked good and some of them looked less good, and they did lots of meta-analyses. And this is the meta-analysis in critically ill patients, and effectively, unfortunately, in the ICU, the predictive ability of NGAL wasn't perhaps as good as it was in paediatric cardiac surgery or even in the ED, and the AUC, which is a way of measuring the sensitivity and specificity of a biomarker across the range of its concentration, was only 0.73, which is sort of moderate. So the sensitivity and specificity were only in the kind of 75% at the optimal level of cutoff. And that's actually not terribly good for a diagnostic test. It means that overall populations you can identify, but if you have an individual patient at an individual one-off level, that's not probably going to give you enough good information in terms of the pre-test probability and the post-test probability of AKI to really make a meaningful difference to your clinical practice. And the worse, it seemed that while NGAL worked quite well in people who had normal renal function, in chronic kidney disease in this study it seemed to perform much more poorly. That may be because the timescale of NGAL release is different in chronic kidney disease, and other people showed that later on in patients with chronic kidney disease NGAL could be more useful, but that may not be clinically useful because you can't necessarily time identify the timing of the renal insult. So NGAL seemed to work better in children, it seemed to work better in cardiac surgery than critical illness, and it seemed to work better in people with normal baseline function, and it seemed to work better in the urine than the plasma. So it wasn't fantastic. And partially this was related to the fact that NGAL's a marker of systemic inflammation, and perhaps even the plasma NGAL, some people theorised that plasma rather than urine NGAL could actually be going up indirectly. It wasn't coming from the kidney, but the kidney injury was associated with lung injury, associated with raised plasma NGAL, and there was one paper here that demonstrated lung injury in association with kidney injury and NGAL expression in the lungs. So, the corollary of all this, though, how to criticise NGAL a little bit, was that we're comparing NGAL against serum creatinine-based diagnosis of AKI, and I've just told you that serum creatinine is latent and imprecise, particularly in people who are more sick and have reduced creatinine production. So the question is, if you've got positive NGAL but no creatinine, is that just a marker of systemic inflammation, or is that a marker of the fact that you're actually got kidney injury but your creatinine hasn't reflected it? And there's some studies to illustrate that this NGAL positive serum creatinine negative group have worse mortality. They don't require as much renal replacement therapy as you might expect, but they have worse mortality. And the question is then, is that reflecting the fact that there is pleiotropic effects of acute kidney injury beyond the kidney itself and beyond the renal dysfunction? And actually the mortality was greater than those of creatinine rose, but the NGAL was negative. Okay? But without data about what's really going on in the kidney, it's difficult to interpret this. And there's another study here which essentially shows a very similar thing, that the NGAL positivity here with serum creatinine negative and the serum creatinine positivity with NGAL negative are intermediate, but actually the two together were associated with a much higher mortality overall in this, which is another kind of multi-centre ED study. And this is another urinary biomarker called KIM1 that performed similarly in this. And this, again, is another study which is a very interesting study, actually. I think this is a study of patients who had cardiac arrest, and they looked at urinary and plasma NGAL, and they distinguished patients who had a creatinine increase in cardiac arrest, they had true acute kidney injury, and then they had those whose creatinine went down, which was the majority of patients, and those whose creatinine remained unchanged. Okay? What you can see is those whose creatinine remained unchanged had significantly higher NGALs than those whose creatinine decreased. And actually these are all the creatinines of the patients in this study, and what you can see is the majority have a creatinine decrease. And this is because of all of those metabolic factors affecting creatinine production, as we say. So actually, if you account for those, this group with an unchanged serum creatinine have in fact would be predicted to have a decrease in GFR. that almost completely offsets the reduction in creatinine production. Okay? And unsurprisingly, then, they have an elevated NGAL. And in addition, this group had significantly worse survival than this group. So the group who had acute kidney injury had terrible survival. This group had significantly worse survival than this group where the majority of the survivors were allocated. So that's, again, some supportive evidence that the biomarker here is giving us some useful prognostic information. So, but it does say that there's a significant difficulty in determining whether these biomarkers are useful because creatinine doesn't really help us. Now, there are some better biomarkers. This is probably the thing that's you're going to hear about. There was a study done where they actually prospectively went out to screen about 300 molecules to see if they could identify very good biomarkers and see if they could identify biomarkers that work well in combination. And they were trying to predict the development of AKI in the kind of 12 hours after ICU admission. So this is the screening process that they did, but they wanted to predict clinically significant AKI in 12 to 36 hours after ICU admission. And they found these two molecules, tissue inhibitor metalloproteinase and insulin growth factor binding protein 7, and they multiplied these two together as their biomarker result. I have some difficulty with the just choice to multiply them together, but that's by the by, it was patentable. And what they found is that these markers were much better than the existing biomarkers that had been developed in previous studies in terms of their AUC, their ability to predict, and particularly in interesting groups like sepsis and surgery, where some of the biomarkers hadn't performed very well in the past. Okay, so that was good. And what they did in the study was actually they had a development cohort and then they had a validation cohort which was completely separate. So it was done very well. And these markers have now been approved by the FDA in the US. They've done a further subsequent validation study as demanded by the FDA, and it's going to be, aggressively marketed in the US as a method of diagnosing AKI in a variety of situations. And it is associated with some really patient-centered endpoints. They've got this thing which is the combination of death, renal replacement therapy, or development of CKD essentially, and an increasing level of the combination biomarker was significantly increased with, it related to a very significantly increased risk of this patient-centered endpoint. And the really fascinating thing about these markers is they're actually related to the cellular pathophysiology of AKI. They're related to something called cell cycle arrest, which is what damaged tubules will undergo. Okay? But in a real-world population, they're still not performing brilliantly, but this is compared against creatinine. So renal biomarkers may be very good, but we don't really know how to move forward. We want to identify where patients are in the pathway of AKI. So what we've got to decide is if we have a biomarker that's very good, maybe this nephrocheck biomarker, which is the one I've just alluded to, is very good, do we do nothing? Do we say we don't really have any information about how to treat these patients? We know how to treat patients with an elevated creatinine. We don't know how to treat patients with a positive nephrocheck. Do we stratify care? Do we give an intervention? Do we stratify discharge and follow-up? We could say that we don't have enough evidence to guide my therapy. I want to gather some evidence, okay? And you could also say, is the ICU the right place, okay? In the ICU, what are the interventions for AKI? They're best supportive care, avoiding secondary injury, timely CRIT to clinical indications, okay? That's ICU care for AKI. What is good ICU care anyway? Best supportive care, avoiding secondary organ injury, and timely organ support to clinical indications. So you could argue that making an AKI diagnosis in the ICU doesn't really affect your management. And the things in the AKI treatment bundles are relatively limited to these kind of very supportive interventions. So it may be better to study patients in other settings such as the ward, the ED, or the community, and use ICU more as a biomarker-driven intervention than a place to study the biomarkers, okay? And it may be particularly useful in excluding AKI in terms of people not needing ICU. So that's what I think. And you need to think then about what your outcomes are going to be. And they probably shouldn't just be seeing whether they have a change in their creatinine. You maybe need to measure GFR formally, or chronic kidney disease, or couple of biomarkers to an interventional study and see if it improves the outcome. So you need to think about what intervention you might use. You don't know if that's effective in early AKI. So you've got this problem where you've got an intervention that's unproven and a biomarker that's unproven. You're not going to be able to prove the intervention without a better biomarker to drive it. You can't prove the biomarker because you don't have a suitable outcome. There may be study designs that can test it, okay? So you could test both things in a pragmatic study. So you could do something where you have a biomarker-driven therapy and you have a control arm where you measure the biomarker but you don't give the clinician that information, okay? And then you would need to compare this group to this group as well as this group to this group, okay? And overall in this group versus this group. Now there's only one study that's been kind of gone to this kind of design, and unfortunately it was a study looking at erythropoietin therapy and acute kidney injury, which was not what I would have chosen as my intervention, but and it was negative. But it was, some people have studied this kind of design. Okay. Alternatively, you could just have a clinical trial and you could say, all I'm going to do is stratify my randomization in each arm to a biomarker, and because it may be that my intervention, let's say it's next dopamine 3.0 or whatever it is only beneficial in patients who have the positive biomarker, or maybe it's only beneficial in the patients who don't have the positive biomarker, who haven't yet acquired acute kidney injury. That's a plausible scenario. So this is the kind of design I think that you need to really justify the use of biomarkers. So I think still that biomarkers need validation, and we need to think about what therapies we were going to use in terms of biomarker-driven therapy. Thank you.